everyone. Welcome to This Day. It's Thursday, October 15th. Now, we have a couple of meetings to tell you about this morning. 9:30 this morning, we have the United Architectural Controls and Standards Committee meeting. And as I mentioned, that's 9:30. We have the GRF Strategic Planning Committee meeting, and that is at 11:45. And then at 1:30 this afternoon, we have the United Governing Documents Review. Now, you can follow along with these meetings at lagunawoodsvillage.com/meetings. On our show today, we have Dr. Paris, and she is with RadNet. She talks about imaging and a variety of new things that are coming down the pike. And then we also visited with Judy and Lauren of the Florence Sylvester Senior Center, and they have some updates regarding the flu clinic, excuse me, and then a bunch of other things that are going on internally at the clinic to help you out. All right, let's go ahead and go to our resources that we normally give you for COVID-19. We have covid19.ca.gov. OCHealthInfo.com is where you can get all of the charts that we normally show you on Mondays and Friday. And they have a hotline, 714-834-2000. You could always go to our website, which is LagunaWoodsVillageAlerts.com. Email us at info@LagunaWoodsVillage.com. Now, as I mentioned, we do have a heat advisory for the remainder of the week until tomorrow. We will go ahead and keep you abreast of the different temperatures that we're experiencing, but by Monday it looks as though we are going to start a cooling trend. Today, 95-66, tomorrow 94-66. By Sunday, we are still high at 84-63, but as I mentioned, Monday, we are cooling down with a partly cloudy day, 80-64. Now, our sunrise was at 6:56, and our sunset will be at 6:16. Now, take a look at this cutie. Ivory, just darling, very cute, and that was sent in by Mark Weiss. So Mark, thank you for sending that in. If you have an adorable photo of a pet, please email it to us at lagunawoodsvillagetv@gmail.com. When we come back, we'll have Dr. Ferris. Stay tuned.
As a friendly reminder, cast your third mutual ballot by using a dark pen to fill in the oval. Place your ballot in the secret ballot envelope. Then, insert into the yellow postage-paid return envelope and seal. On the back of the yellow envelope, sign your name. Mail in plenty of time to arrive before November 2nd. Or hand deliver to the Community Center ballot box by November 2nd. This is an important election proposition. Please vote.
Welcome back. Well, today I am joined by Chico Paris, who is with RadNet, and she is a diagnostic and interventional breast radiologist. Well, welcome to the show. Nice to see you again. It's been a while.
It's my pleasure. Thank you for having me again.
You know, before we get into talking about mammograms and some things that you guys are looking for, can you tell me what the definition of your description of your title is?
So my name is Dr. Chico Paris, as you stated. I'm medically trained as a physician scientist. So I have a medical degree and a PhD degree. And I'm specifically dedicated to mammography or breast imaging. And because we do diagnostic and interventional procedures, you kind of have the dual title of being a radiologist and interventional radiologist at the same time.
I see. Now, do you actually perform any surgery?
So we do minimally invasive procedures such as ultrasound-guided core biopsies, stereotactic guided core biopsies, MRI guided core biopsies, ductograms, needle wire localizations for patients preparing for surgery. All of these procedures are performed while the patient is awake. We just do local anesthetic.
Oh, okay. Well, good. Well, I always wondered what the interventional portion of the title was, so I appreciate you telling me that. Thank you. And then let's talk about some of the things that you guys are looking for when you do have a mammogram. I mean, obviously there are many different things that you're looking for, so maybe you can help us understand what they are.
So when a woman's mammogram is obtained, there are several things that we look for. first, we start off by assessing the breast. So for each breast, there are two views that are obtained. The craniocaudal, where the breast is placed on the detector and the compression paddle comes down. And then the medial lateral oblique, where the breast is compressed from a medial and lateral position, so to speak. So the woman would remember having her arm in the air. So what we do is that we look to make sure that the nipple is in profile, that's one. We make sure that we can see to the posterior breast tissue, and so that we can make sure that we can visualize the pectoralis muscle. And then the key thing is also to make sure that there's no motion on the film. If we lose any of these things, then the patient would get a recall for repeat imaging. The next thing that we assess is the breast tissue density. And that is where we quantitate the ratio of the glandular tissue to the fat in the breast. And then the tissue is placed into one of four categories. Either woman is fatty, she has less than 25% glandular tissue. She is scattered, she has between 25 and 50%. She's heterogeneously dense, between 50 and 75%. Or she's extremely dense, she's 75 to 100%. Once we've then quantitated the density, we then move on to assessing the pathology in the breast. So we look to see if there are little white dots that we call calcifications. We check to see if there's any distortion or pulling of the tissue. We look to see if there are any masses. At the end of that assessment, we then, because it's a screening mammogram, she either gets a BI-RAD 0, saying that the radiologist would like to do additional imaging of her breast, a category 1 saying it's completely benign, nothing is seen, or category 2, yeah, we see some calcifications or masses, but they're stable, they've been there before, no need to worry, return in 1 year.
Oh, okay. All right. Well, I didn't realize there were so many different things. Now, one thing that I, remember, of course, when I have mammograms is, the machine itself. It's been around for a while, and I know that it's had a lot of advances. What are some of the latest advances now?
So right now we have 3D mammography that's offered. And essentially for that imaging study, we take multiple slices of the breast that then get reconstructed. And so it allows us to look through very thin slices to see if there are any new changes or development in the tissue. So it has a good advantage for the patients who have scattered or heterogeneously dense breast tissue. For the patients who are fatty breast tissue, you don't need that because the breast tissue shows up as dark and cancer shows up as white. So white on dark already creates a contrast. For the patients with a category 4 extremely dense breast tissue, the research studies actually shown that the sensitivity of 2D and 3D match, because at that point, the woman has no fat in her breast to create contrast, and essentially it has the same sensitivity as the 2D.
So is breast size a factor in breast cancer occurrence?
Got you. So in reference to breast size, there's been shown no direct link between the size of a woman's breast and whether she's susceptible to getting breast cancer. However, the research has shown a direct link between a woman's breast tissue density and breast cancer. So because a woman would have the 4 categories of breast tissue density as I previously described, if you're category 3 heterogeneously dense or category 4 extremely dense, it means that you have more than 50% of glandular tissue. And so small masses may get obscured. And so the radiologist may not be able to see through that tissue to find those masses when they're, less than 2 centimeters. And so the woman might then come in with a mass that's large enough that would then be seen by the radiologist, regardless of if she has dense breasts or not. So what's recommended as of 2013 in the state of California, when the dense breast law was passed, was that we now have to inform women of their breast tissue density so that they know that they may benefit from supplemental imaging, such as a screening breast ultrasound, or if she's high risk, screening breast MRI.
I see. Okay, good. Now, if a woman has a family history of breast issues, does she need to do anything differently than someone who has no family issues?
Exactly, yes, she should do things differently. So for those women, it's recommended that earlier on, as long as they can document their family history and even utilization of their own personal history, they should meet with either their primary care doctor, their OB, or even a surgical specialist, like a breast surgeon. And at that point, they would start off by doing what's called a risk assessment. This is where they would assess based on the information provided about the patient's personal history and family history, and using one of the many models out there. The most popular one right now is the IBIS model. And that's where they would get a number that is reported by the system as to the risk factor for the patient. If that patient has a greater than 20% increased lifetime risk for breast cancer, it's recommended that she should have supplemental imaging through breast MRI. If she is less than 20%, then she should have a screening breast ultrasound. Now, besides the genetic testing, besides the risk assessment, they would also do genetic testing. And that's when, through blood work or mucosal swabs, they would look to see if there are any gene mutations that are being passed on through the family line that puts this individual at risk for breast cancer. Because if there are, then once again, she should benefit from supplemental imaging.
Right. Okay. Wow. All right. Well, this is very good information. Thank you. Now, in regards to men, I'm sure they're going, oh, well, I don't need to listen to this, but they do. I mean, there are cases of men who are getting breast cancer. Tell me about that, and what are some things they need to be looking for?
Right. So there are no screening guidelines for men in the general population per se. But for men who are high risk, either have a family history or have a predisposition for breast cancer, it's recommended that they should have additional assessment. Because in men, although they have a 1 in about 800 increased lifetime risk for breast cancer, and versus women who have 1 in 8, they still are at risk, as you stated. So it's recommended for these men who are high risk that they should have clinical breast exams performed semi-annually by their clinicians starting at age 35. That male should also be doing self-breast exams like women once a month. And it's recommended that they actually should start off with a screening mammogram at age 40 to get a baseline if they have a strong family history. And that's because, just like women, yes, age is a factor in the relationship of men getting breast cancer, but also hormonal use. So men take medications, and some of these medications can actually lead to changes or elevations in the estrogen level within the body. Also, men who are obese are also at risk. And men who have liver disease, such as cirrhosis of the liver or any type of liver dysfunction, because the liver catabolizes or breaks down estrogen for excretion, if the liver is not functioning properly, then once again, it will build up in the system. So for men who have a family history for breast cancer, it's actually recommended that they should get monitored just like a high-risk woman.
Wow, great information. And so now at least we can say, all right, men, you need to listen as well, because this is something, even though the ratio isn't quite as high as a woman's, they still need to be concerned. So great information. Nice to see you again, doctor. I appreciate you taking the time.
No, thank you for inviting me once again. It was my pleasure.
All right. You have a great day, and we'll talk to you again.
Thank you. Likewise.
All right. And we'll be right back after this.
United Mutual members, here's what you must do to ensure your votes count and are not disqualified due to unsigned ballots. With a black or dark pen, fill in the oval to the right of the candidate's name. Do not mark an X or a check mark, or your vote may not count. Place your ballot in the secret ballot envelope and seal. Do not write on this envelope. Insert the secret ballot envelope into the pink postage-paid return envelope addressed to United Laguna Woods Mutual and seal. On the back of the pink postage-paid return envelope, provide your address and signature on the signature line and mail. Unsigned return envelopes will not be counted. Mail-in ballots must be received at the post office box by 11 a.m. on November 2nd. Hand-delivered ballots placed in the ballot box in front of the community center must be received by 5 p.m. on November 2nd. Call the Inspector of Elections at 855-240-0363 if your ballot is lost or damaged to have a new ballot mailed to you in 1 to 2 business days.
Welcome back. Well, today I am joined by Lauren and Judy, who are here from the Senior Center, the Florence Sylvester Senior Center. Well, welcome, ladies. How are you today?
Great. Thank you.
Okay, thank you.
Yes, I'm really glad you both could join me because obviously we're in the month of October and that means flu season. And then of course, on top of COVID-19, we have to worry about flu season. So before we get into that though, Lauren, tell me a little bit about what case management does.
Sure. Case management is that we advocate for our seniors. We provide resources. We provide safety in their home. When we are not in COVID, we're allowed to do home visits. And we try to keep people as independent as possible. We provide resources such as placements, such as insurance, caregiving, any kind of resource that you need. We help people with paperwork. Sometimes we help people connect with insurance, such as HICAP and Medi-Cal, things like that.
And then, is there ever a charge for any of the services that you do?
No, we are a nonprofit agency, so we request donations, but we do not turn anyone away who's a senior who needs help.
Okay. And I know you have a couple of different things that you like to do. So I think you mentioned like veterans, you have a veterans thing.
Yes, we do have veterans. We do refer people to veterans resources. They can apply for aid and attendance benefits, things like that. We also do, another part of our case management is we're doing well check phone calls. So with that is if anybody needs a phone call and would like to be on a well check list, they can call the senior center and get that.
So what does a well check involve?
So we just call them, make sure they're okay, see if they're isolated, depressed, make sure that they're safe, make sure that if they need any resources, we can connect them with. Some people like to be called once a week. Some people once a month, but we do contact them and make sure that they're okay.
So Judy, I know you're going to talk to us about flu shots in just a little bit, but tell me a little bit about what you do for the senior center.
Well, I actually work through a grant program with AGRO that comes to AGRO. I'm a registered nurse and my second master's is a gerontologist. So I help with the home visits or the telephone visits we're doing now, unfortunately, and able to step in on a part-time basis and help with projects such as helping set up the flu clinic and so forth.
Okay, good. So tell me about these well checks now. What are you finding is going on with some of the people that you're calling?
Well, of course, right now, what we're seeing when we're calling the people is they're extremely happy to get a call. If they need any additional services, it's the lonesomeness and the isolation we're really extremely concerned about right now. So I think that's our main concern at this point in time.
So Lauren, when you come across the social isolation, let's try that again, the social isolation and loneliness. Okay, one more time, because I'll have to cut that out. So in regards to social isolation and loneliness, what are some things that you're talking to the people about?
Well, sure.
Either one, we can have Judy. Well, let's talk with Lauren first, and then Judy will have you come on next.
Okay, that's fine.
Okay, so about 28% of older adults live alone in the United States. Research has linked depression, anxiety, high blood pressure, heart disease, Alzheimer's, a weakened immune system, and even death if you're socially isolated and lonely. One thing is that if you are engaged in meaningful activities, into socially speaking with other people, even if it's on the phone, it seems to be better and it improves your health and well-being. One thing that we suggest people to do is go on our website, which is myagewell.org. And you can look at the link where it says information and resources. And on that, we have virtual classes. We have information on how to get on our meals programs. We have all that kind of thing. So we ask that people go online, and if they cannot go online, then they can call us at the senior center and we can connect them and we can do well checks. Most seniors who are above late 80s, early 90s have more difficulty with getting online. So they can pick up the phone, they can call their family members, call their friends. It's important for their well-being to do so.
Right. And Judy, I would imagine being, from the background of gerontology in nursing, do you have medical advice for them when you talk to them?
It depends on what the situation is. I can give some medical advice, but I leave most of that to the physicians since I don't know them personally for a long period of time. So it'll be very general healthcare education.
Right. And then I would imagine if there was a situation, you would definitely advise them to see their doctor.
Absolutely. Absolutely.
Okay. All right. Well, excellent. One other thing that I wanted to cover is the medical equipment. So you have a kind of like a loaner program.
Yes, we have an actual room of durable medical equipment. We provide Depends, we provide Insure if we have it. We have people who donate to us, wheelchairs, walkers, canes. They come to the center and they either come up and tell us that they have medical equipment, we can get it from their car. And then we also have where people come and need the medical equipment. So we provide that for them also. It's just based on what we have coming in and what we have going out.
That's a nice program. Some of these things are kind of expensive. These walkers these days are, well into the hundreds of dollars. And so if you're able to help somebody along with some of these fancy walkers, that's great.
Yes, we have plenty of walkers. A lot of people want the walkers with the seat, and sometimes we get those. Those are a little bit harder, but those are around $300.
Oh, wow.
So, and of course, Medicare doesn't cover that. They only cover a regular walker. A lot of people want shower chairs. Those go quickly because Medicare, again, doesn't cover it. So things that Medicare doesn't cover, we also have too, and it does save you a lot of money.
No, that's a great idea. That's awesome. Okay, so Judy, flu shots, it's on the top of most people's brains right now because we've been talking so much about COVID-19 and how we were waiting for a vaccine for that. So I was talking to a doctor the other day who talked a lot about, even though we don't have anything for COVID right now, but just getting your system in tip-top shape will help you for the future. So tell me how getting the flu shot can help us.
Well, the flu shot will hopefully keep any signs of flu away. It is not going to be effective on COVID-19, and we know that at this point, but we want to reduce the chance of getting the flu at all. And definitely it will reduce the chance of the flu becoming a hospital issue for you. We don't want any chronic disease is getting worse for you. And we know that those people over the age of 65 are more inclined to get the flu, any type of flu, due to the normal changes in the immune system. So we want to lower the risk for people that has heart disease, diabetes, asthma, any of the chronic diseases. Extremely important. Also important because the flu virus changes every year, and the vaccine actually is adjusted every year to meet those changes. So you need to get one annually, and the previous one has waned by the time the year passes. So it's important to reduce hospitalization from the regular flu, to reduce, of course, any deaths. And we do have to think about saving our healthcare resources for those people who have gotten the COVID-19.
Exactly.
So we're trying to keep everybody well.
One thing I think is interesting is that, we've been talking so much about COVID-19, but, it's a coronavirus, just like many of our other viruses that we've had over, a very long time. So I think what's interesting is I had seen a sheet the other day that pretty much reminded us of everything that we're doing today by washing our hands, wearing the mask, doing all of that stuff, pretty much could be applied to the flu, don't you think?
It is. And what they found in the Southern Hemisphere is that actually so far this year, the flu has not been as prevalent down there. And it is probably because of wearing masks and the extra attention. So it's extremely important that we continue that over this whole next year, probably.
Yeah, I would agree. So, I mean, I think we're probably, well on our way to understanding both the coronavirus as well as the flu right now. Now, I know you guys have a flu shot clinic coming up on October 30th. So, Judy, just why don't you tell me what the times are and how that's going to work?
There will be, I believe it is A through M will be 1 to 2, and M through Z will be 2 to 3. It's going to be a drive-through clinic, so you don't have to get out of the car, but you still need to wear your mask. And there will be a nurse on each side of your car if there's 2 of you in the car or even 2 in the back seat for any reason. Also, there will be 1 station for those people who may have to walk in from some other form of transportation.
Okay, all right, that's great. Is there a charge for the vaccine?
No, there is not.
Wow, that's great. I mean, boy, that can be quite a savings if someone maybe didn't have it covered through insurance.
Absolutely. No, they're all of the shots will be free.
That's really nice. Lauren, lots of vendors involved, which is awesome that we have some great local folks that are helping you out. And then, so every person that gets the shot gets a little goodie bag.
Yes, so everybody who goes through the drive-through clinic gets a little goodie bag, and we have some sponsors for that. It is sponsored by Memorial Care, and the vendors that are adding to the goodie bag are Aetna, Amadeus Marketplace, Attentive Home Care, Bud and Bloom, Connect America, Encompass Health, Hope Senior Benefits, Kaiser, Monarch Healthcare, O'Connor Mortuary, Personalized Senior Placement, and Walker Insurance Solutions. So if you want to get a goodie bag, come and get a free flu shot. We serve anyone 18 and above.
Wow, it's early Halloween. We get a goodie bag.
Yeah.
Yes. It's the day before Halloween.
I know, that's good. That's great.
Yes.
I love it. Well, I really appreciate you guys doing all the things that you do. I mean, such great programs for people in need and those who may just want to chit chat on the phone or, visit with you guys. I think that's really great. So thank you so much for being with me, and we'll get the word out about the flu vaccine and the flu clinic.
Thank you so much.
Thank you, Lisa.
All right. And we'll be right back after this. Just as a reminder of what shakeout drills. So they would like you to participate just as a reminder of what to do. Drop, cover, and hold on. If you want more info, shakeout.org/California. And then the end of today, midnight, is the last day that you can fill out the census. And you guys all have done a great job, so make sure you do that. Have a great day in the village today. We'll see you again tomorrow. Bye-bye. Tip, toss, take action. Don't give mosquitoes a fighting chance. Don't give mosquitoes a fighting chance.